Hello, my name is Dr. Gunjan Shah. So today we are going to discuss hemodynamic changes during pregnancy. Which are the hemodynamic changes that occurs during pregnancy and how it has impact on any patient who has any cardiovascular disease. So pregnancy is a dynamic process which is associated with significant physiological changes in the cardiovascular system. These changes are the mechanisms that the body has adopted to meet the increased metabolic demands of the mother and fetus and to ensure adequate uteroplacental circulation for fetal growth and development. Some anatomical changes which occurs during pregnancy are change in the cardiac radiographic outline silhouette which occurs in the pregnancy. Heart is pushed slightly upwards and outwards and slight rotation to the left due to elevation of diaphragm consequent to the enlarged uterus. Pregnant women may have some benign pericardial effusion which may increase the cardiac silhouette. Maternal hemodynamic changes. Pregnancy is associated with vasodilatation of the systemic vasculature and the maternal kidneys. The systemic vasodilatation of pregnancy occurs as early as 5 weeks and reaches its peak during the mid and second trimester, progressively decreasing in the later stage of the pregnancy and return to the pre-pregnancy levels immediately after the delivery. Hormones like estrogen, progesterone and relaxin play a significant role in causing the vasodilatation. The vasodilatation of the kidney results in 50% increase in renal plasma flow and glomerular filtration rates, and by the end of the first trimester, this results in decrease in the serum creatinine, urea and uric acid levels. So the reason why the regurgitant valvular lesions are better tolerated during the pregnancy is the vasodilatation of the systemic vascular systemic vascularity. Clinical findings which is normal in pregnancy is the apex bit may be shifted to fourth intercostal space about 2.5 cm outwards to the mid clavicular line. As we have discussed previously, the heart is shifted outwards and upwards slightly and rotated slightly towards the left. So this results in the shifting of the apex bit. Resting pulse rate increases approximately by 10 beats per minute. Systolic murmur may be heard in apical or pulmonary area due to increase in the blood volume and cardiac output during pregnancy, which is the result of decreasing peripheral vascular resistance and increasing plasma volume, which we will see later on in the slides. A continuous hissing murmur, memory souffle heard in second and third, right or left intercostal space is due to increase in the flow through internal memory vessels due to increased blood supply to the breast. Third heart sound due to rapid diastolic filling and rarely fourth heart sound is maybe one can auscultate that which is considered physiological during the pregnancy. ECG reveals normal pattern except possibility of left axis deviation sometimes. Transthoracic echocardiographic changes which one may observe during pregnancy. Left ventricular wall thickness and left ventricular wall mass increases by 28% and 52% above pre-pregnancy values respectively throughout the pregnancies. The temporary cardiac remodeling is associated with volume is because of volume overload, and ventricular hypertrophy is accompanied by upregulation of vascular endothelial growth factor and increased myocardial angiogenesis with no increase in cardiac fibrosis. Typical transthoracic echocardiographic finding in a normal pregnancy include mild forced symbol dilatation, changes in right atrium and right ventricle are typically greater than the left atrium and left ventricle because of the compliance and thickness of the baseline thickness of the ventricle wall. Transient trivial mitral regurgitation, physiological tricuspid and pulmonary regurgitation may be seen. Aortic regurgitation is not seen in normal pregnancy. As we know that cardiac output is the product of stroke volume into heart rate. So cardiac output starts to increase from fifth week of pregnancy and reaches its peak of 40 to 50% at about 30 to 34 weeks. Thereafter, the cardiac output remains static till term. This is the reason since the cardiac output is maximum during 30 to 32 weeks, the possibility of worsening of underlying stenotic left-sided valvular heart disease is maximum by 30 to 32 weeks, and it is generally believed that if the patient is beyond 32 to 34 weeks, since the cardiac output now remains static, the patient will tolerate the pregnancy relatively well. Cardiac output is lowest in the sitting or supine position and is highest in the right or left lateral or knee case position. The reason of this will be seen later. Cardiac output increases further during labor, approximately 50% increase from pregnancy values, and immediately following delivery 70% over the pre-labor values. which is very significant and very important to note. Overall maximum cardiac output is seen immediately after delivery. The second part where the cardiac output is maximum is second stage of labor, followed by late first stage of labor, followed by 28 to 32 weeks, followed by early first stage of labor. So this is the reason why balloon mitral valvuloplasty or balloon aortic valvuloplasty may be considered during second trimester between 26 to 30 weeks, as the cardiac output is reaching its maximum at around 32 weeks. The charts mentions the same only, and there is cardiac output has been mentioned in value in liters per minute. As you can see, the purple bar immediately postpartum has the highest cardiac output during the pregnancy and peri-pregnancy period. Mean arterial pressure also rises. Cardiac output returns to pre-labor value by 1 hour following delivery. Remember, this mentions 1 hour after the delivery, the cardiac output value reaches pre-labor, which is as such 50% higher than the pre-pregnancy values, and to the pre-pregnant level by another 4 weeks time. The increase in cardiac output is caused by increased blood volume and to meet the additional O2 required due to increased metabolic activity during pregnancy. The increase in cardiac output is chiefly affected by increase in stroke volume and increase in heart rate. Cardiac output early in gestation is thought to be mediated by increase in stroke volume, whereas in later part of the gestation it is thought to be because of increase in the heart rate. As you know that blood pressure is equal to cardiac output into systemic vascular resistance. There is a decrease in arterial pressure, including systolic blood pressure, diastolic blood pressure and mean arterial pressure during pregnancy. Diastolic blood pressure and mean arterial pressure decreases more than the systolic blood pressure due to smooth muscle relaxing effect of progesterone, nitric oxide, prostaglandin and atrial natriuretic peptide. Systemic vascular resistance decreases, which leads to decrease in blood pressure. So in spite of large increase in cardiac output, the maternal blood pressure eventually decreases. Maximum blood pressure decrease is seen in second trimester. As we have seen, the maximum decrease in systemic vascular resistance is in second end of the second trimester during third trimester. So the maximum decrease in blood pressure is also seen during that time. The overall decrease in diastolic blood pressure and mean pressure is around 5 to 10 mm mercury. During pregnancy, blood flow through lungs is facilitated by decrease in pulmonary vascular resistance, which primarily occurs in early gestation. This is a normal physiological change to accommodate the increased blood volume and oxygen demand of growing fetus. The primary hormones affecting pulmonary vascular resistance are estrogen and progesterone, both of which have vasodilatory effect, leading to a decrease in pulmonary vascular resistance as their level rises throughout the gestation. This table mentions the same thing as we have seen previously. It is just the summarization of the previous findings. So the cardiac output changes by around 40 to 50% near term from pre-pregnancy values. Stroke volume is increased around 30%. Heart rate is increased around 15 to 17%. Blood pressure is generally decreased by 5 to 10 mm mercury, not significant drop. Venous pressure is generally increased by 100%. It is almost double due to growing fetus size and growing uterus, which comprises the IVC. Colloid oncotic pressure is relatively same, or it may decrease by 10%. Systemic vascular resistance and peripheral vascular resistance decreases by 20 to 35%. Supine hypotension syndrome is seen during late pregnancy because of gravid uterus, which causes compression of IVC during supine position, which leads to hypotension and tachycardia and syncope. Is relieved by turning the patient to the left or right side. This is the reason why also the blood pressure is highest in left or right lateral decubitus position and is least in supine position because of decreased preload. Sympathetic activity in baroreceptor. Decreased baroreceptor sensitivity causes a significant decrease in signals sent to the brain regarding blood pressure changes, which eventually leads to increased sympathetic activity, and because of this it leads to higher baseline level of sympathetic tone. Decreased pressure responsiveness to angiotensin II, norepinephrine and vasopressin has been observed during pregnancy. Mild reduction of baroreceptor sensitivity is normal, but significant reduction leads to preeclampsia, where blood pressure regulation is already compromised. Changes in RAS system in pregnancy. In a normal pregnancy, there is a substantial activation of RAS system. The enhanced activity of RAS occurs early in pregnancy with increase in plasma volume starting at 6 to 8 weeks and rising progressively until 28 to 30 weeks. During pregnancy, as estrogen production increases from ovary and placenta, which enhances the production of angiotensinogen from liver, making it a substrate for enzyme renin, leads to increase in angiotensin level. But remember that there is a decrease in angiotensin to sensitivity. This activation maintains blood pressure and helps retain salt water in pregnancy, as maternal, systemic and renal arterial dilatation creates a relatively underfilled cardiovascular system. During pregnancy, relaxin stimulates increased vasopressin secretion, resulting in increased water retention. Progesterone is a potent aldosterone antagonist that acts on mineralocorticoid receptor to protect against hypokalemia. Maternal ANP level increases by 40% in third trimester and up to 150% compared to normal in first week postpartum, suggesting a significant role in postpartum diuresis. This figure shows the same thing, that because of the volume expansion there is atrial stretch, which leads to secretion of ANP from atria, which leads to inhibiting aldosterone and ultimately natriuresis and diuresis blood vessel. Changes in renin, angiotensin, aldosterone system during pregnancy has been mentioned in the chart, which we have discussed previously. This is just summarizing the effect. This is the absolute value changes in plasma volume and red blood cell mass. There is increase in 30 to 40% increase in blood volume from 4 liter to approximately 5.5 liter, and plasma volume is increased more compared to RBC mass. So plasma volume is increased by 50% and RBC mass is increased by 20 to 30%, which leads to overall blood volume increase of 35 to 40%, and there is relative increase in hemoglobin. There is absolute increase in hemoglobin, but there is relative decrease in hematocrit because of more increase in plasma volume. So there is relative hemodilution, which leads to decreased viscosity, which leads to effective uteroplacental circulation. So advantage of hemodilution in pregnancy is, as we have seen, just that the diminished blood viscosity causes optimum gas exchange between maternal and fetal circulation, and it protects mother against the adverse effect of blood loss during delivery. Neutrophilic leukocytosis may occur up to the extent of 8,000 cells per millimeter cube, and even to 20,000 in labor due to effect of estrogen and cortisol. Blood coagulation factor. Pregnancy is a hypercoagulable state, and one can say increase in 50% of fibrinogen level from baseline non-pregnant state, which leads to also along with increased globulin level leads to decreased blood viscosity, and ESR may be higher up to 4-fold, can be considered normal during pregnancy. As such, ESR has got a very little diagnostic value in pregnancy. Changes in blood coagulation factor. So platelet may remain same or may decrease by 15%. Fibrinogen is increased by 50%, and ESR may be increased up to 4 times than baseline. The interrelationship of changes in the major variables that contribute to the cardiovascular changes in pregnancy are compared in the following chart. So cardiac output is increased comparatively more as the pregnancy progresses, and highest in labor is same with heart rate. It is also seen maximum during labor. Systemic vascular resistance and blood pressure may fall. Maximum effect is seen in third trimester. And changes in renin, angiotensin and structural changes can be seen as mentioned in the chart. Thank you.